Just as a point of interest, this is the 19th Scholars Day that we've held annually for almost 2 decades now. Scholars Day has evolved and grown quite a bit over time, and it has been great to connect it with a number of research opportunities for students, ranging from the undergraduate research fellowship to the TAMS research scholarships in the summer. And we have seen many students flourish and move on to great things after the opportunities they've had to conduct research here. This is a starting point for students to present in a familiar, usually familiar environment. And they oftentimes will go from this environment to present externally at conferences and other settings. So we are glad to see you here, Alex and Wilson, and hopefully we'll have a third student who will join us. And the title, I suspect everyone has that already, and it is on, they have the title on the screen of a review of colonic anastomotic leakage and prevention methods. So, Alex, Wilson, you have the mic.
Alrighty, yeah, thank you so much. Okay, so today we will be presenting a review of colonic anastomotic leakage and prevention methods. My name is Alex Fang.
I'm Chao.
And we did this project under the guidance of Dr. Melanie Ecker. So anastomotic leakage is defined as a leak of luminal contents from a surgical joint between two hollow viscera. This is widely considered one of the deadliest complications of colectomies and colorectal surgeries, as it is a major cause of postoperative mortality and morbidity, as it can increase the need for reoperation and can generally have a greater impact on the quality of life. So what causes this? It is caused by anastomotic dehiscence, which occurs in varying rates depending on different surgical factors. To the right, you can see a table with the different types of factors and how it affects the leakage rates. And this can generally occur in colectomies or colon resections, which are surgical procedures to treat the large intestines by cutting out a certain portion that is diseased or infected. And although we are focusing solely on colonic anastomotic leakage, this can also occur anywhere else in the gastrointestinal tract. So preoperative risk factors. So these are risk factors that are considered prior to the surgery itself. These are divided into two types, non-modifiable and modifiable risk factors. So for the non-modifiable risk factors, there are factors such as gender, age, and diabetes. So for example, generally males are harder to operate on due to the narrower abdomens that we have. Mortality rates are also generally increasing with age, specifically after around 60 years. And although diabetes has no direct correlation with anastomotic leakage rates, it can lead to higher mortality rates. For modifiable risk factors, there are factors such as obesity, smoking, and alcohol. And in general, through many studies, these are found to be highly associated with anastomotic leakage rates. So intraoperative risk factors, these are risk factors that come with techniques or prevention methods during the surgeries themselves. So first up, we are discussing surgical techniques. There are several types. First off, we'll be focusing on laparoscopic versus open surgery. And so laparoscopic surgeries are when you make a small incision, in contrast to open surgeries where a large incision is made to perform the surgery itself. And although there is no statistically significant difference between the anastomotic leakage rates between these two types of surgeries, laparoscopy, although it is more difficult, it has been shown to reduce morbidity amongst other clinical benefits, which is why it's more preferred. Staples versus hand sewn techniques are also very viable. And similarly, although there is no statistically significant difference between these two, staples are generally easier to use. and it has been shown to reduce anastomotic leakage, specifically in ileocolic anastomosis. Compression rings, these are an alternatives to sutures and staples, and these are a relatively recent development, I would say. How it works is that it compresses two bowel walls together to create a simultaneous necrosis, and through this, it can decrease scarring and inflammation of the tissue. The most modern versions have shape memory and superelastic properties that make them more applicable in different types of different varying thicknesses of tissues. So SPS tubes and colo shields, these two techniques never really entered widespread use due to the rise of laparoscopic surgeries, and for the SPS tube, there were very few studies supporting its use. The SPS tube was used for adequate apposition and to facilitate sutures, while the colo shield was designed to be sutured to the submucosa of the bowel, proximal to the anastomosis site. Mechanical bowel preparation, this was another technique used. It is an oral preparation given prior to the surgery to clear fecal matter from the bowel. So obviously this will reduce the amounts of infection that might come after the surgery, and etc. When paired with antibiotic therapy, mechanical bowel preparation has been shown to be effective in reducing anastomotic leakage and infection. Another technique used is intraoperative air leak testing. And although its effectiveness is inconclusive, how it works is that it is performed by insufflating air into the rectum. And this was used to test for any risk of anastomotic leakage. You know, you find where the air is leaking out and there might be a leak there later on. So two more types of techniques are splenic fixture takedown and goal-directed fluid therapies. For splenic fixture takedown, if it is performed properly, it can achieve a tension-free anastomosis by providing sufficient colonic length. This technique is effective, but it can lead to increased operative time, which can lead to other risks. For goal-directed fluid therapies, so how this works is that it measures cardiac output to perioperatively guide intravenous fluid. And although this has been shown to reduce postoperative complications, it has not been shown to reduce anastomotic leakage.
Okay, so postoperative management techniques. So first, to detect anastomotic leakage, a CT scan or SDC are the most common methods. However, using and detecting biomarkers in acute phase proteins is a new promising way for detection. After detection, a severity grading score will usually be given, and they're classified into 3 grades, grade A, grade B, and grade C, depending on the amount of intervention needed to treat the anastomotic leakage. So firstly, antibiotics are usually used in combination with draining or reoperation. They're commonly the first line of treatment, and generally leakages of less than 3 centimeters can be managed with antibiotics alone. Draining. The literature regarding draining is pretty inconsistent, but has been shown to increase surgeon's confidence. The exclusion of NSAIDs or non-steroidal anti-inflammatory drugs has been shown to help anastomotic leakage because with a meta-analysis showing that NSAIDs may increase the risk of anastomotic leakage. But many of the studies included in that meta-analysis were flawed, but it should still be avoided. So stenting shows promising results, but complications may arise from migrations, perforations, and hemorrhages, so its usage is still under review. And vacuum therapy promotes healing of wounds by enhancing formation of vascular tissue and increasing vascularity. It delivers a negative pressure to a leak site to collapse the cavity and create a seal, and it's a very promising way to treat anastomotic leakage. Some emerging techniques are polyphosphate therapy, which reduce bacterial production of collagenase, which has been shown to cause anastomotic leakage. And this could be a non-invasive way of treating anastomotic leakage. And surgeons have started to reinforce the staple line with bovine pericardium strips to decrease the risk of anastomotic leakage, but there's no evidence to support that it actually does. It has been shown to help with anastomotic vascularity. And fibrin glue is popularly used in obesity surgery, but its effectiveness is disputed, but it's most effective in patients with small cavities. And a new hydrogel based off of marine inspired, based off of mussels and barnacle cement proteins and xanthan gums has been developed to adhere to wet tissues, which has been shown to increase bursting pressure, but it's only been tested in rats, but it can reinforce the anastomosis. So in conclusion, a definitive treatment or preventative measure has yet to be developed. Likely a combination of intraoperative and postoperative methods for best treatment of anastomotic leakage. Stents and vacuum therapy are the most promising ways to treat anastomotic leakage, but further research should be done. And future studies should also focus on the role the intestinal microbiome has on leakage, biomedical devices such as stents, compression rings, and biomarkers. And yeah, that's our presentation. Thank you very much for listening.
Yeah, thank you. Thank you, guys.
Thank you, gentlemen.
Yeah.
So let's open for the audience to ask any questions they may have.
No question?
Well, I was
That's
wondering,
too soon.
was that published somewhere?
Yes,
Yes,
we
it
were
was.
fortunate to be able to publish this review to the Journal of Clinical Medicine this past December, I believe. Yeah, great accomplishment! Yay!
Excellent. A lot of great work in the scientific literature will come out in the form of reviews, oftentimes finding gaps and making connections that other people haven't done before. And so that's important. But let me ask you about your expectations and hope for some laboratory work of your own or some hands-on efforts of your own.
Yes, I guess I can start off. So due to COVID restrictions, that has been obviously kind of hard. But for me, I have been going back to the lab around once a week. And Dr. Ecker's, one of her projects right now is centered around using shaped memory polymers to create another type of device for colonic anastomotic leakage to prevent it. And I have been basically doing tensile testings and various tests on these shaped memory polymers that we've been fabricating and seeing how that holds out, basically. Yeah. So that has been my more of a hands-on research. Yeah.
Mm-hmm. And do you think those your work with those polymers may be connected with potential procedures related to anastomotic leakage, perhaps? Is that a connection you may be drawing, or not necessarily?
Yes, hopefully, hopefully, I guess. I think there's still a lot of work to be done. But basically, all I'm doing right now is I'm basically testing the properties of the polymers. But shaped memory polymers in general are a very promising, I guess, promising device for future research. Yeah.
Excellent. How about you, Wilson?
So I haven't been able to do much because my parents are more paranoid, I think, about COVID. So I haven't been able to go into the lab. I've gotten my COVID vaccine recently though, so I've been thinking about going to the lab over the summer if I'm allowed to do that. Wait, are we allowed to do that as a senior?
I think we are.
Okay, that's good. So yeah, hopefully once after I get my second dose of vaccine, which is like in May, I can go into the lab and work on shape memory polymers. So yeah.
Oh, very good. And I think the word you were looking for was cautious, and somehow
Yeah,
paranoid came
cautious,
out.
not paranoid. I didn't mean to demean my parents like that, but maybe I mean cautious. Yeah.
Mm-hmm. Oh, very good. Are there other questions from the audience? Well, let me say that this was a great way to accommodate the needs of the time right now by not when you couldn't be in the lab this last summer, and yet you were able to do something very productive that is contributive and that obviously was perceived as such by reviewers when you submitted that manuscript last year. So that's great work. Thank you, Melanie, for guiding them. And I know that people like you and Bill certainly have come up with a number of great opportunities for our students to continue to learn and pursue research. So thank you.
Yeah, thank you. I mean, we were just trying, yeah, to find really something for the students to do. But one kind of funny side story here. So since that was submitted and peer reviewed, one of the peer reviewers actually had a comment and said, "Oh, that reads like high school students have written that." And so I commented back, and yes, indeed, these were high school students. I'm so proud. So yeah, that was just
Well,
that yeah, I just found very funny. But yeah, in the end, he congratulated them on their accomplishments, and it was finally published. So I think yeah, they did a very good job.
yeah, that's great. And Alex and Wilson, if you have hopes to conduct research after your TAMS graduation, that is actually possible. Just be in touch, and then we can talk about any logistics, and we'll see. But thank you, everyone, for coming. Thank you, Bill, for as usual supporting our students and being a great presence and a great mentor for them in so many settings.